right, moving on, we are going to hear about family history next, and I would like to welcome our next speaker, Dr. Julia Smith, who is a clinical assistant professor in the Department of Medicine, and she is also the director of the cancer screening program here at Perlmutter Cancer Center. So let's welcome Dr. Smith.
Nice to be here, and thank you for coming out in the rain. So you may be wondering what they have me up here for when I deal with hereditary cancer syndromes. You know, this field really exploded in the 90s. I'm a medical oncologist. My research, my Ph.D. research is in molecular biology and cell biology. So I was trying to figure out in the 90s and before how to take care of oncology patients, and what I wanted to do was find a way to prevent the cancers. That's what everybody wants to do. Well, we couldn't really figure out how to do that until the BRCA genes. You've probably heard about them, the BRCA genes, those Angelina Jolie genes were cloned in the mid-90s. When the Angelina Jolie genes were cloned, the BRCA genes were cloned, it became clear that there are cancers that are caused by genes that we're born with, hereditary predisposition to cancer. That was a novel idea. Before Mary Claire King cloned those genes, all doctors poo-pooed the idea that cancer could be caused by genes, that there was a genetic basis to cancer. So it turns out that there is a genetic basis to many cancers, and colon cancer is one that we came to understand after the BRCA genes, which helped us understand breast and ovarian cancer risk. Colon cancer genes became clear. And as time has gone on now, through the 2000s, we have learned more and more about colon cancer genes and the hereditary patterns people face. The reason it's so important is that if you find that you have one of these genes, and more genes, I'll show you, are being discovered, you can tailor your screening and your prevention, and you can often keep yourself, and we can keep patients from ending up with colon cancer. So, let's see. This is just to show you the list. You see, at least a quarter, at this point now, at least a quarter of patients with colorectal cancer have genes they were born with. That's called a germline mutation. You can't do anything about the genes you're born with, but you can do a lot about what you do to protect yourself. Quarter of patients with colorectal cancer, at least, have genes they were born with that predispose them to a high lifetime risk of colon cancer. And then you can see this list of genes that's expanding. I'll mention some of the old ones and some of the new ones, but they're expanding at a really pretty rapid rate. It's a very evolving field. You know, we thought initially that there were about 2 to 3% of patients, under 5% of patients who had colorectal cancer where you could attribute it to the genes. But as we found more and more genes, we find more and more people who we can identify as at high risk, and we can prevent those cancers. So this is just to give you an idea of when you're looking around at your family, because the family history can be very, very helpful in understanding whether there's a genetic predisposition. So you look at your family and you see that if, for the average person, if their population average risk of getting colon cancer in their lifetime is under 2%, about 1.8%. But you can see with more affected relatives in the family, if you have 2 or more affected relatives, you have 3 times that, at least 3 times that chance of getting a colorectal cancer. So what I thought I'd do is pick out 2 syndromes to give you an idea of how these colorectal cancer genes that predispose to cancer work. There's basically 2 kinds of syndromes that one can have. You can have what's called a polyposis syndrome, and that's when the gastroenterologist goes and looks and does your colonoscopy, and they see many polyps in the colon. In some syndromes, the polyps are so numerous that you can't find any normal mucosa. It's just carpeted. The whole colon is carpeted. Those are called polyposis syndromes, and that absolutely indicates a genetic predisposition to colon cancer. Then there's another kind of syndrome called hereditary non-polyposis colorectal cancer syndromes. That's the Lynch syndrome, among others. The Lynch was the first identified, and I'll tell you a little about those genes, but there are many more genes that have been identified. And in that case, it wasn't so obvious to us that the person was going to get cancer because they'd go to the gastroenterologist. The gastroenterologist would look in their colon, they'd see a few polyps, and they'd say, okay, we took out a few polyps, but they didn't know that that was a hallmark in that person of a hereditary non-polyposis cancer syndrome, and that person had an extremely high chance of getting colorectal cancer. And if we identify them and those genes in them, we can know how to increase the screening and prevent their cancers. So I'll start with this. I think it went over here. Start with the non-polyposis, hereditary non-polyposis Lynch syndrome, which is sort of the first non-polyposis syndrome to be identified. Now look at this. If you are born with a change in these specific genes, everyone has to be born with the genes that cause these syndromes. But if you're born with certain mutations in these genes, then you have, up to the age of 70, you have an 80% chance that you will develop colorectal cancer. 80% chance just because you were born with certain mutations in these genes, particular genes. You also, for women, have a high chance of developing uterine or endometrial cancer. By the age of 70, about a 60% chance of developing uterine cancer. That's very high because uterine cancer tends to be a very rare cancer in our society. So if you know that a person has a high chance, an 80% lifetime chance of developing colorectal cancer because they have these genes, and a high chance of developing uterine cancer, you can do things to prevent it. With this Lynch syndrome, there are other cancers that are associated with these mutations at birth, and I've listed them down here for you. You can see there are a lot of them, but gastric or stomach and ovarian are the two most commonly associated with the colon cancer and the uterine cancer of Lynch syndrome. So we have measures if we can identify these people to protect them. Here is a slide that I prepared to show you a polyposis syndrome, when there are all those polyps blanketing the colon. So there's something called FAP, familial adenomatous polyposis syndrome, and something called AFAP, attenuated familial adenomatous polyposis syndrome. And every single study that we have shows that these people, unattended, will essentially 100%, between 99 and 100%, will develop colon cancer, colorectal cancer, if we don't intervene. And then there are these other associated genes that I'm going to show you in a minute that are sort of in between the polyposis syndromes and the non-polyposis syndromes. So as a medical oncologist, I first got interested in taking care of patients with this because they came to us having had something like colon cancer. And then we started to see that these patients, as time went on, happened first with breast cancer, and then it happened with colon cancer in this country. We were able to greatly increase the cure rates and greatly prolong survival. As we were able to prolong survival for these cancer survivors, we started to see second cancers in some of these patients. So why were these people getting second cancers? Well, it turns out, again, that many of them are getting it because they had this hereditary predisposition from these genetic mutations at birth. So it's very important, and it became very important for us as oncologists to find these patients, because you don't want to have a patient who comes to you with colon cancer. You do everything you can to get them through that diagnosis, and they survive it just to be brought down by a second cancer that if you had known they had a risk for because they had a gene, you could have prevented it. So here is what happens to people who have Lynch or hereditary non-polyposis syndrome if you aren't aware of it and trying to screen for these things. People with Lynch syndrome have up to a 50% chance within 15 years of that first diagnosis of cancer of getting one of those second Lynch cancers that I listed for you in the previous slide. So many of those cancers are totally preventable, but you have to find these patients. These are the second cancers with the familial adenomatous polyposis syndromes. And there I would say, as you can see, there are a lot of them, but they're relatively low in incidence. The one I want to point out is that if you or your family has someone with a familial polyposis syndrome, it's very important if they have children to alert the pediatrician, because those children, for the first 5 years of their life, have an increased incidence of hepatoblastoma, and they need to have special surveillance with a blood test and screening for the first 5 years of their life. So these are the standard guidelines that we now follow for people who have Lynch or hereditary non-polyposis syndrome. They don't go for 5 or 10 years waiting for their next colonoscopy, because the mutation in the gene, it causes the function of that gene to be altered. And you heard that it takes years for a polyp in the colon to advance to cancer. Not so with these mutations. Those polyps, you have to pick them up and get them out right away because they change to cancer quickly. So the guidelines are clear. If you have someone with these mutations, you start colonoscopy at the age of 20 to 25, every 1 to 2 years, and after the age of 40, they have to have colonoscopies every year because those polyps will rapidly evolve into cancer. But if you get them out every 1.5 years, they're not going to get cancer. Because of those other cancers I told you associated with Lynch syndrome, in particular uterine, which is that 60% chance of getting that, and the high incidence of ovarian, which is about 13%, which is very high for ovarian because the normal incidence of ovarian cancer in the general population is 1%. So 13% is high. You do, as soon as childbearing's over, you do a hysterectomy and an oophorectomy, get out the ovaries and the uterus. Now here are the screening guidelines for patients who have gene mutations that cause the polyposis, the familial polyposis syndromes. Because the FAP, the familial adenomatous polyposis syndrome, has a predilection for the rectum, those children, and sigmoid, they have to start sigmoidoscopies every year at around the age of 10 to 12. And then whether you have a familial polyposis or an attenuated familial polyposis syndrome, you have to have colonoscopies, full colonoscopies, and you should look at the upper tract as well every 1 to 3 years, beginning in the early 20s. So it's a lot of screening, but it is absolutely life-saving. So, the management is this kind of screening we're talking about, the kind of surgery that you heard about, and people do elect. We have many patients who have this high incidence of colorectal cancer who don't want to go through screening every single year and polypectomies repeatedly, and we have patients who elect a total colectomy, and as you heard from Dr. Greco, people adjust very well to a lifestyle with that. We don't really have, we are exploring chemoprevention in this, and we don't really have a lot of good data for it, but aspirin, non-steroidals, and oral contraceptives are being studied. I wanted to just quickly show you the new genes that are on the new genetic panels that we do looking for hereditary cancer genes related to colorectal cancer. And you can see This is just, I won't go through them all and what they do, but basically the MSH3 causes this Polyposis syndrome, the RPS20 causes a kind of the non-polyposis, the Lynch syndrome, and then these new genes, all, the NTHL1, the GLANT12, and the RNF43, well, the RNF43 causes a kind of what's called a serrated polyposis syndrome. That's the kind of polyp that you were hearing about earlier, where it's hard to get it all off the colon in a polypectomy because it's flat against the colon wall. So you have to keep going back and making sure nothing grows up. But the others all cause the kind of polyps that are lollipop polyps and colorectal cancer. So what can we do about this? The genes, you have to get screened. If you think that your family looks suggestive for any of these things I'm talking about, your family history, these kinds of cancers are popping up in your family, then get screened for a genetic mutation because it is absolutely life-saving. And then obviously we have to take care of our weight. Don't smoke, don't drink much alcohol, and do eat healthy and exercise. We have pretty good data about some effective protection with oral calcium and maybe aspirin. And the point I really want to make is that you can all of us can do this. We can all identify for ourselves whether, and it's very important that we identify it because the doctors are doing their best, but they can't do it without you. You have to look at your personal history, your family history, look at your lifestyle, get screened and go get genetics if it looks like there's something that you could benefit from. Thank you.